And good morning, everyone, or good afternoon, wherever you are. Thanks for watching our presentation on preventing suicide using motivational interviewing, skills to promote confidence and hope. I'm Dr. Brian Connors, and I'm here with Dr. Brad Lundahl. This video is intended for Army OTs and Army OTAs as a continuation of our telecom presentation this morning. So if you missed the telecom, you can have this presentation video as a supplement, or give it to people who missed the presentation the first time around. So, and here we go. So a little bit about the agenda today. We'll just do an introduction about suicide and why it's such an important topic right now, and maybe a little bit about motivational interviewing, and then get into the meat of it, the concept, and reviewing the different skills in motivational interviewing that you can use with soldiers or their families who are suicidal. And then had this been in a live format, we had a little bit of a Q&A format. So we'll just do the first two. So I'll just kick it off to my partner, Brad.
Greetings. So I appreciate the opportunity to be here. As far as who I am, so I have a PhD in clinical psychology from Northern Illinois University. I'm a tenure professor at the University of Utah. And then sometimes when we professor types are teased, they say, oh, that's just academic. So what you're talking about doesn't really apply on the front lines. So beyond kind of talking and teaching about motivational interviewing and doing some research on it, I practice it, I own a clinic, and then we've developed an online training program. So we hope that this information will help you, help the soldiers and their families kind of move forward. And we're just focused specifically on suicide today.
Yeah.
Oh, and I've had the good fortune of working with Dr. Bill Miller and Steve Rolnick, the two co-founders of motivational interviewing. So Brian's controlling, we're figuring this out. We're learning how to co-operate our slides here.
So that's me, Brian Connors. So my PhD is not in psychology. My PhD is in rehabilitation science, but I am an occupational therapist, and I'm the president of ESIM. We provide motivational interviewing training for, all different professions, from social work to counselors, rehab, all different types of professions. So my research when I was doing my dissertation under Brad was in motivational interviewing, and using motivational interviewing in what can be considered a time-crunched area of occupational therapy, which is in hand therapy. So getting people motivated, getting them to take some steps, some actions for their health. So I wrote a couple papers on that, on motivational interviewing. And then I'm also a former occupational therapist in the Army. I'm also 65 Alpha. So suicide equals pain, right? So suicide is the second leading cause of deaths in the military. It's increasing every year, not just in the Army, but in every branch, not just in active duty, reserves, National Guard, everywhere this problem's getting worse. It's getting worse in the military. It's also getting worse in the civilian side as well. But it's interesting that it used to be that suicide was less in the military than it was in the civilian world. And now that's flipped. Now it's worse in the military, and it's progressively getting worse and worse and every year for the past 15, 20 years. So here's a little chart and graph about how it's getting worse. You can see the different service branches, whatever service branch you're in, and what those rates look like, and how it's progressively getting more and more. Unfortunately, once we leave the military and go to the VA system, it's getting worse there as well. So progressively worse. So you can see from on the right that that suicide is definitely an issue. That's the theme here. It's an issue, and it's an issue that really needs more and more attention every year as this problem gets worse and worse. So we'll look at the predictors of suicide. So there's some of the things when you think of suicide that you could probably guess what would lead to it, right? Feeling trapped, hopelessness, stress, pressure, work, finances, those types of things, loss, hurt, bereavement, losing people, right? You get these things with suicide, but also thanks to a certain virus, it's much worse this year. It seems like everybody is stressed out. Coronavirus has not helped with that, has not helped economically, has not helped with families staying at home together, all these different things. It's gotten worse. And then of course it's led to an economic crisis. Whether or not that gets worse, that's more doubt, maybe more hopelessness, and we have more of a situation. So a lot of stuff going on in 2020. So military, you have all that, and then you have your deployments you have to deal with. You have your PTSDs, you have your traumas, and statistically you have more access to firearms. So there's the means, right? You have all those things on top of what civilians have to deal with. So we can maybe see why there is a higher incidence or maybe prevalence of suicidality in the military. But occupational therapy, so we're here to support. So occupational therapists are there on the front lines. You're there talking to the soldiers, talking to the patients. You're there. So you have the opportunity to screen them if they're maybe exhibiting some signs of suicide, and you're there to support them in time crunch situations, or if you're there in the behavioral health area, maybe more of an intervention and working on that suicidality or that hopelessness that many of the soldiers are feeling. Just a little bit about the research. So I've talked a little bit about MI. I'm not sure what your experience is with MI, whether you've heard of it or not, or whether you're trained in it. But MI was originally developed about 40 years ago to treat addictions by the same gentleman who coached Brad and who taught Brad motivational interviewing. And it was used in addictions. There's thousands and thousands of studies on MI in a myriad of different areas. Not so much on suicide and MI. There's more and more, it could be in the dozens, but that's when you have thousands in other areas, it's not that much. And there's not that much really in the military realm, whether that's the veterans, the VA, or whether that's active duty. But what is out there it's promising. And that's what all this preliminary work, pilot work is saying. It looks good, it looks great, we just need more research and more studies. And as these rates get worse and worse, we're probably going to get more funding and more research to show the effectiveness of MI in suicidality. So we've broken it down to two parts. I understand in the military you have a lot of these encounters which may be brief, where you're casting, you're splinting. It's a brief encounter. You don't have all of this time that you might have in more of a behavioral health area, right? Where there you may have unlimited sessions of 50 minutes or 60 minutes. Whereas in some of these, whether you're on a med surg floor, whether you're in a hand therapy clinic, whether you're all these different areas, it's a quick hit, it's brief, right? So if that soldier's, if it's acute and if they're really suicidal, obviously we're gonna refer them out and get them the help right away. But if you're seeing the risk factors and all these things piling up, really what our goal is there is to get them to engage in some type of longer therapy, whether that's OT and behavioral health, psychology, social work, whatever it is, doesn't matter. But getting them to work on all of those stressors and all of those things they're having on their lives. So first we'll just talk a little bit more if you just have just a few minutes to work with them, do it with the soldier, and then moving on from there. So what I'll do here is I'll pass it on to my partner to talk about our acronym and the next step here.
Yeah. So context certainly matters where you practice. In my world as a psychologist, I got to see people for 50 minutes, since that's a long amount of time. Often that's not your case. So we'll look at this idea of, occupational therapy, then MI cross to suicide prevention. So we came up with an acronym, may or may not help you, but just this idea of, asking, so when people come up, to you, just ask, and we'll give some examples a little later about their relationship to life, their relationship to thinking about suicide. And then depending, we'll talk about this idea of maybe referring them to social work, medical, or other kind of practices. And then that last one, motivate you being the patient or the soldier to kind of live well. So ARMY, to live well, is the acronym we devised, and hopefully it's helpful. I'll give it back to you, Brian. Oh, maybe this is still me here, right? So, so one of the things that MI does is it provides a bit of a roadmap for kind of where to go. So that slide's kind of tiny there, but what you can see in there is there's the this idea of a small talk. So imagine someone's coming into you for just OT. Hey, you might talk to them a little bit. How's your day? What's going on? And then MI is always about promoting engagement, lowering resistance. That's that top arrow across the those other colored boxes. And then we're also assessing, intervening, engaging, trying to, participate with the patient on some level. And then from an MI perspective, we want to do kind of what's the goal, like where we want to focus. And then the second step is like lifting that motivation to help someone move forward. And then lastly, developing credible plans. Now, MI provides lots of skills. We won't be able to go over all those today. Today's just kind of a brief touch into some ideas about motivational interviewing. Some of the skills that we know are, I'll give you some examples there, Brian, if you get that slide. So, partnering language. So we want the people to feel close, not alienated from us. So using we, together, our, join, collaborate. Permission questions to emphasize autonomy, reflections, simple reflections, complex reflections, double-sided reflections. So there's many different kind of skills on reflecting, emphasizing autonomy, like, hey, this is really your choice. I've got an idea. I'll be interested to hear what you think about it. Some people, appreciate this approach. Others don't. What's your thoughts? So lots of skills around emphasizing autonomy, exploring and setting focus. So sometimes be guiding the person through our session, building credible plans, and then a skill that we'll review today is empathy, normalizing, empowering, and a few other skills here and there. But there's lots of skills. We won't hit all of them today, but they do exist. Okay. What you might see here, Brian, just kind of run through these slides here. So we're in this idea of, someone comes in, we might look at this idea of like, what do you want to focus on? Why is that important? And how might you move forward? Again, the process, always assessing, context, culture, symptoms, patterns, etc. All right, next slide there. That's couched in this idea of small talk and then wrapping it up. So there's, if you will, the logic to motivational interviewing. Okay, that's one I think is kind of the same here. So we're going to go through what, why, how, and then just go through a few more there, Brian. And I think right now we're going to focus on, so is from an occupational therapist, an OT perspective, how can we do a suicide screening? And so we'll jump into that in this next slide here. Okay. So Brian, I think this is, do you want me to go over this or do you want to jump in on this?
Yeah, I can go over it. So in OT, starting with the Army acronym that we had introduced on the last slide. So just asking, do you mind if I ask you a question about how you're doing emotionally psychology? Sometimes this, in some medical settings, this is even mandated. It's just part of the screen, but not necessarily all the time. So we definitely just want to start by asking that question, right? So it could be something as simple as, I'm asking this question, and you might have heard suicide is really on the rise. So I'm just asking, and you did mention that you're having a lot of these stressors going on in your life. Are you thinking about contemplating suicide now, or have you done that? Have you done that in the past? So just asking that question, and you could do that in a couple different ways, right? Just paraphrasing on what you could do, whatever works for you, but just asking that question. So what if the soldier, the patient says, yes, I'm contemplating suicide? Assess, are they going to do it right now? Right now, imminent. We got to do something. We got to go wherever that is. And you probably know what that is in your environment as to getting them care and staying with that person if that is the case. Not so much imminent is what we're talking about now. If it's not, there's really two different ways you can do that. We can have that brief intervention with them, which is a mental health referral, and just getting them, and even still using motivational interviewing, but motivating them to get engaged in that referral. You can refer, they're just not going to go, right? You want to get to refer them and get them engaged in that referral. That's your goal, getting there and using a little MI in that respect. But also, what if you have that, if you're in behavioral health and this is really, it is your world, then we want to motivate them. We want to motivate you to live well. So using that Army acronym to improve their lives. Brad, do you want to take this one here?
Yeah. So we're going to take on a quick skill here. So Brian, if you want to run through all those, like, let's say about like if someone says yes, so that's a pretty vulnerable moment, right? So they're in OT, they probably weren't expecting this question. and you've asked them, hey, have you contemplated suicide? And they say yes. So then we want to do empathy, normalize, and empower. And let's look at some examples of this. If you want to click through those slides, Brian. So empathy would be like, hey, yeah, if you're feeling suicidal, life can be overwhelming. Or you might also think, if this person's feeling suicidal, they must be experiencing a lot of stress, a lot of pressure. Maybe they've lost purpose, right? So you might, again, identify empathy toward them in this realm. Say, yeah, like it can be tough to transition out of the military into civilian life, or it's really difficult to have lost mobility, and that's painful. And then that normalizing, it's like, you know what, people think about suicide. That's not uncommon. And if we think about form and function, so form, empathy, function, help the person feel validated, help them feel heard. Normalize, we don't want them to feel alien, like there's something wrong or some sort of problem with them. So it's like, yeah, people think about suicide. That's not uncommon. And then lastly, this idea of empowering. And in this situation, let's get you some help. So empowerment's about connecting them to resources that can help them move forward. You don't have to say it exactly like this. But it's a pretty good formula: empathy, normalize, and empower. So I think we've got a few examples here that maybe we'll go over here. All right. Do you want me to take it? So imagine a client says this: thanks for being honest. Contemplating suicide likely means you're struggling in life, and that deserves attention. I'm sorry to hear. Can we discuss options to help you feel like you want to live again? So maybe break that down for us, Brian. So you click through that. I think it goes to some, yeah.
So the thanks for being honest, that's the, it takes a lot of courage to come in here and say that you're thinking about suicide. That takes a lot of guts, so having some empathy there, but normalizing it as well is, actually I hear that quite a lot with soldiers that are about to transition out, and it's quite common. So normalizing it and making that soldier feel like they're not an outcast, that this is something that a lot of people go through. And then that deserves attention. I'm sorry to hear that. So just some genuine empathy. What it would be like to transition out and you don't know what you're going to do. You don't know where you're going to live, or you've been in for 20 years and this is all you know, right? So that's heavy. So sorry to hear that. But then this last part is not just focusing on just the negative or all this weight that's going down on them, right? It's empowering them as well to do something. We're working together to empower. Can we discuss options to help you feel like you want to live again? So that's the empowerment part, is working on something and not just leaving them with this heavy thing, or directing them and saying, well, you're going to do this to get out. I know there's a lot of that probably in the military, but this is going to be a little bit more of a collaborative approach. So the affirmation, thanks for being honest. Normalizing it. There's the empathy and empowerment. So here we go again, the empathy. Life can be tough. Thinking about suicide, this is another example. Normalizing it, that it's too common among soldiers. The empowerment part, would that be something for us to discuss? Not staying on the negative, but turning this lemon into a lemonade, which is something that we'll discuss in a little bit. But something that we like to talk about and is called the we bombs. Brad mentioned that earlier. What's a we bomb? So it's this collaborative approach. So let us take a few minutes. It's not, okay, I'm going to take a few minutes and tell you what you need to do. That's not very helpful. It's not an MI approach, not very client patient centered, right? So let us take a few minutes to discuss how you can move forward in life so you want to live. Would that be okay for us to do now? So that last part is really important. That last part, which is the permission question. Okay, we could have just say, let's take a few minutes and discuss how you want to move forward. Well, that sounds really directive. That last part makes it feel like it's a team. We're gonna tackle this issue that you're having together. Would that be okay if we did this together? Because it's your life, but we can help each other. So that's a really important skill to learn and to use, is that permission question. Hey, Brad, do you want to take this one?
Sure. So then imagine the client says, sure, I'm interested to hear what might help, right? So assuming it's positive. And so here, the mental health treat. So here, if you want to click to that next slide there, Brian. So again, breaking it down. So one of the things that we try to do with motivational interviewing is almost like the Rosetta Stone. We want to take language and break it into its different component parts. So there's some purple language. If you throw up the next, hit the click button there. So this is about trying to promote hope and confidence. Like, hey, behavioral health treatment can be very effective in helping people understand themselves and develop credible plans. So we're trying to, if you will, just help the person believe in, that there's some support for them. I know lots of people have benefited from, medications or counseling. So that might be normalizing and promoting hope. Here's a clear plan. Like, hey, we've got a great referral source on our base. Like, or we can get you to the VA system. We can get you to, medical or social work, and that they're very helpful. And then this idea of like, can I link you to them? So rather, like Brian said, rather than saying like, hey, I'm going to push you over to social work, like a permission question, can I link you to them to see if you can get some support? So we're trying to do that permission question and also, offer some, hope or motivation for them to move forward. So pretty simple skills, this idea of empathy, normalizing, and then empowering. We don't have to go specifically in that order, but it seems to work pretty well with patients. Okay. So let's look at another skill set here. So if we click through this one, I think we're going to go to flipping concerns to goals. Brian, do you want to take that one or do you want me to?
So, this, I mentioned before that there's two parts, some of the time where there's not as much time, and then there's times when you're going to have more time, depending on what your practice area is and where you are. So one of the more important skills, or one of the many skills, is flipping concerns or complaints into goals, which is like turning lemons into lemonade. And everyone's heard of that analogy. So first notice the concern. The person is taking their life. I know that sounds pretty simple, but sometimes you're just not catching the cues. You're just not hearing it. You're focused on something else. You're having a busy day, whatever it is. But there are these cues, or maybe even explicitly state something about taking their life. Just noticing it. That's the first step there. And then think empathy. What's their experience? Imagine walking a mile in their shoes. What if they were on deployment, they lost somebody, they lost a family member? Just think about what it's like to be in their shoes just for a moment. And it really gives you a genuine empathy and a genuine empathic response to what it is that they're going through. But again, we can't focus on that. What's the opposite of the lemon? It's lemonade, right? So if they're feeling hopeless and sad and those types of things, the opposite of that, pretty simple, is wanting to live, vitality and purpose. So you might say something like, I hear you're having suicidal thoughts. You're thinking about taking your life. That's tough. Everything you've gone through, losing your mother and your father in that month, that's a lot. That's really heavy stuff. And all this stuff that you have going on in your unit, gosh, I'm sorry you have to go through all that stuff. Instead of focusing on that, let's turn this into some lemonade. Can we work together to find a way that make you want to live? Can we work on helping you feel what's the opposite of lemons is lemonade? Hopeful, vitality, and purpose again. And notice that we use the permission question there. So the concerns, the lemon, the possible goals, the lemonade. Again, I'm depressed. So what's the opposite? You want to feel alive, have purpose and energy. There's hopelessness. You want to help the soldiers see promise and help them believe that things will work out. Same thing with trapped. And then, even as something as severe as suicide, is to help them feel alive again. And that's really when you focus on, is something that what we'll talk about is change talk. And we'll get more into that. So again, hear the concern, provide empathy, and then think about the opposite. You've thought of taking your life. That's really tough. And everything that you're going through is just really heavy stuff. But how about we can work on something to make you feel alive again? Would that be okay? Doing the permission questions. Brad, you want to take this one here?
Sure. So assuming the client said yes, and maybe we've got them to a referral and we have a little bit more time, we're now going to talk about how you might try to encourage the person to want to live. And so we're going to talk about this idea of change talk and promoting a motivation for life. So then in that ARMY acronym, we're now on that MY part, that last part. And by the way, my guess is in OT, it's kind of the same, meaning think about the flow here. You've got small talk in the beginning, some wrapping it up at the end. All along you're assessing, you're looking at symptoms, patterns, et cetera on the bottom, and you're always trying to promote engagement. So where we're going to jump to right now is let's assume that we've got a goal. And in OT, it might be like, hey, I need functioning in my hand to return. in suicide, someone's like, okay, the motivation to live and to kind of want to live. All right, so that's motivation towards life here. So imagine a client says this, yeah, I'm not sure I want to live. I've even thought of suicide, but I know it hurt my kids and my family. I think I can get back on track. I'm just hurting so bad and I lack confidence. All right, so what do you say? Like, so if a patient were to say to something like this to you, what would you say? And this next part kind of really reveals it. By the way, there's red print and green print here. If you're colorblind, this slide may not make a lot of sense. We're just trying to capitalize on the idea of like red light, stop, or it's not going where we want it to go. Green light, move forward. So what we see is that's the same comment, but if we can break it into different parts, let's look at the different aspects of this, Brian. So there's the change talk, that's that green talk, but I know it would hurt my kids and my family, and I want to get back on track. So what I might do right there is say, oh, tell me more about that. Like, how would suicide hurt your family? How would it hurt your kids? And then hopefully the patient say, like, yeah, my kids would be devastated. Like, they've experienced enough loss, and if I were to be, gone, that would be, really difficult for them. And I'm not the kind of person that wants to abandon my kids. So what's just happened right there is I've heard a little bit of that change talk, and I've double clicked on it, or I've reflected it with the hope that the soldier would, advance more green talk. Okay, next, there's this idea of sustained talk, which might keep the person in this situation, contemplating suicide or thinking about it. And again, if where we focus really matters, we'll see that in a little bit. So it's not that I want to ignore the red talk, but I want to, certainly emphasize the green talk a little bit more. Brian and I'll do a little role play down the road a little bit here on that. And then there's that, if you will, symptom talk. Okay, let's go to the next one. So another example here. So imagine, the soldier says, I fear dying. I fear that, if I try to kill myself, yeah, there we go. I fear that if I try to kill myself, I'll fail, I'll be paralyzed, and that would stink or whatever, and it will hurt lots of people. But I just cannot stand to live anymore. I'm so tired. All right, Brian, can you and I role play a bit here? All right, so like if I'm the patient and let's say you want to double click on green talk or red talk, and you're the OT, ask me about one of those, either the green or the red.
Yeah, so thinking about some green talk, and you'll be hurting lots of people. So I might ask you about, well, who would be affected if you had taken your life? When you mentioned hurting people, who would that be, and how would they be affected by that?
Yeah. So mostly my mom, Brian. Like, my dad passed away like, year and a half ago, and she's been in a lot of pain anyway. So if I were to, I cannot do that to her. Like, she's a sweet lady. She's worked really hard. She's given up a lot. And if I kill myself, I know it would devastate her.
Sure. So it sounds like your mother really cares for you. Am I hearing that correctly? Is that your mother cares?
Yes. If I were to stop and talk about some of the skills of MI here, notice that when I say something, it comes out of my mouth and into my ear. And that's going to help motivate me. When Brian reflects it and says, oh, yeah, you care a lot about your mom. She cares about you. And if you were to kill yourself, that would hurt her. Then I've said it once out of my mouth into my ear. Brian's reflected it. It came back into my ear. So that's 2 times this green talk's passing over my consciousness. And it's like, yeah, exactly. And it also probably really hurt my siblings. So the idea is we want more and more of that green talk, and we focus on it. This time, hit the red talk and see what happens, Brian.
So you're tired. How are you tired? What's going on?
I'm just exhausted of life. Like, what's the point? Like, really? Like, I do all this service work. I go over there, I risk my life, I bust it for my company, my country, and then I come back and I can't even get a decent job. It just stinks. It's overwhelming. I'm depressed. My kids don't even want to come around anymore. I'm kind of a monster to them. Like, it's just rough. Like, what's the point?
And how does being a monster, how does that make you feel?
Oh yeah, like, why would I want to be around? Like, I've already hurt my kids. So notice what happens is that from an MI perspective, there is green and red talk. We want to honor the red talk, but certainly focus more on the green talk, because we believe it's going to help that army, like, motivate you towards life and living well. All right, let's go to the next little slide here, Brian. So there's that sustained talk again. Okay, so with green talk, we're going to try to do 3 things. So the first is just recognizing change talk, and then we're going to try to do two other things. One is extending change talk, or getting greedy with the change talk that we hear, and then evoking change talk, like finding ways to draw change talk out. All right. So as far as seeing it, we're not going to talk a lot about that today. Again, lots of skills on MI. We won't go into all of them. Desire, ability, reason, need. So let's break that down just as an OT example first, and then going to suicide. So if you're doing OT work and someone's like, hey, my hand hurts, you want to work on your hand? Like, why do you want to work? Like, I want to work on my hand so that I can get back to fishing. Like, that would be desire. Ability talk, I've done physical therapy before, OT before. I know I can make it better. Reason, there's that, maybe that was the desire talk. Like if I get my hands functioning better, I can actually play golf again, or I can go out and, do some woodworking, which I really like. Need, so from an OT perspective, like if I don't, get my hands functioning, I'll lose out on a lot of, cool opportunities, things I want to do. So that might be an OT world. Commitment, hey, I'll follow up and do the, the homework assignments and the exercises between now and we meet again. So it's commitment. It hasn't yet happened. Taking steps is if someone comes in and says, yeah, I did the exercises 4 out of 5 days last week. I guess there's 7 days in a week. I did it 4 out of 7 days last week. So that's past tense, and they've already done something. Transitioning to suicide. So desire might be like, I want to live, or I don't want to die. Ability talk is like, hey, I was depressed 2 years ago and I pulled myself out. Like, I know I can do this. And they might say, that's green talk, and it's just really hard. That would be red talk. Reason is, I can't hurt my mom. That woman's hurt enough. I cannot hurt her more. Or reason is, I want to be around for my kids. They're going to need a dad and they need someone, and I got to be there for them. Need, my partner, needs me. Like, she needs me to be around. And so if I kill myself, I'm going to leave her in a lurch, and I can't do that. Commitment might be like, I'll follow up with, social work. I'll talk to my, spiritual advisor. I'll talk to my friends. So it's going to happen. Taking steps is, yeah, I've already bought a book on, how to overcome stress. So I'm doing some things. I probably just need to do more. Okay. So brief introduction into change talk. We're going fast here because we don't have a ton of time. So here's from a research perspective, if you want to hit that next slide, Brian. What happens is, we know that the more change talk there is in a consultation, the better it is. So more equals better. Now, it's a pretty aggressive line. It's not quite that strong. But when we've done research on listening to a consultation, the more the client or the patient, if you will, drops green talk into a session, the greater the likelihood that they actually follow through. So if we can get the person talking about their motivation toward life, we believe that will carry over in a positive way. Okay, so let's look at 2 other ideas here. So we've seen change talk, that desire, ability, reason, need. Let's look at the last 2, this idea of getting greedy with change talk, or cultivating it. And there's lots of skills here. We'll just talk about a few real quick. Okay, so one is 2 easy steps. Focus on it. Like, when you hear green talk, just focus on it, because what you focus on, you tend to get more of, right? So just hear that green talk and then, focus on it. Or I got a little memo popped up there. And then commit to it. Like, it might feel like, hey, I'm wasting my time, or maybe this isn't a good use of my time. From an MI perspective, exploring that change talk or focusing on it really does produce, more action outside of the consultation. Okay, so let's talk about this. If you know about motivational interviewing, there's a lot of these skills that you've probably heard of. So open-ended questions. So we want, our patients or clients to give more and more information versus closed-ended questions, which you get pretty truncated responses. Affirmations, hearing change talk that's kind of linked to life and saying, hey, way to go. Reflections, simple, complex, double-sided. So we want to do a lot of reflecting, and then some summaries. Classic MI, we won't spend a lot of time on this. We're going to go to the next one, which is awesome. It's called the Change Talkinator 2025. The big idea there is you're going to put awesome questions in, and you're going to get great change talk on the back side. So let's look at 5 dimensions, and then this is a little bit tricky at times. My invitation is for you to start, playing around with some of these ideas. Maybe try it in your OT work first, where you're more comfortable, and then maybe move it over to, mental health, addictions, areas that are connected to suicide. So there's time, past, present, future, the impact. Did it help, or was it harmful? Did you do more of it or less of it? And then, so those are the three key dimensions that we're going to frame questions around. The target in this case might be mental health, engaging in suicide. And then OT, you can certainly talk about, doing the therapy, doing the exercises. And then the outcome would be, some like health or feeling alive, feeling vibrant, something like that. So let's look at a couple of examples. You can just run through this slide here, Brian. So the target, finding purpose. We're going to look at future tense, what would be helpful, and then more of, and peace of mind. So that's a lot. So if we were together here, I'd say like, hey, produce a sentence that, includes these different components. And look at that, Brian presented one really quick there. That was quick, Brian, nicely done. So if I were to say, hey, in the future, if you go to counseling, so what I see there, I don't know if you can hover over a couple, well, click the next slide there, Brian. So there's the future tense. And so next we have going to counseling. So that's the verb, or what we want to do more of, right? What would be the act? We're doing more of it. Again, if you go to counseling, how will that help you? So there's the outcome, right? In terms of feeling peace of mind. Help was not the outcome. That was the impact, right? Now we can change these around, right? So if I were to say, in the past, when you went to counseling, how did that help you in terms of your peace of mind? I could also flip it and say, hey, in the future, if you don't go to counseling, I think that's the next one, how might that harm you in terms of finding peace of mind? So we can take those 5 different dimensions, the target, outcome, past, present, future, impact, helpful or harmful, or more of or less of, and create some really creative questions. Let's go to the next slide here. So targets, depression. We're going to look at past tense. We're going to look at harmful. So that might be weird. Like, why are we trying to harm someone? Less of, and then suicide, right? So we're not trying to harm anyone. Absolutely not. So in the past, when you neglected working on your mental health or overcoming depression, how did that hurt you in terms of feeling suicidal? And so what we hope the client will actually say here is like, yeah, when I didn't, and Brian, if you want to click through those different, there's like 5 different dimensions will come up. So there's the past tense, target, fighting depression, doing less of it, you neglected it, it was harmful, and then the outcome and suicide. So what we're trying to do here is, again, just produce questions that will generate some green talk. Let's go to the next slide. Okay, so depression, past tense, this will be helpful, more of, and then suicidality. So in the past, when you focused on overcoming your depression through cognitive behavioral therapy or whatever, how did that help you? That's the impact in terms of feeling suicidal. So just a really brief introduction to ways of generating questions that can draw out that green talk. And then when you hear the green talk, we want to focus on it, right? Like just ask, tell me more, give me some examples. How would that really impact you so we get more green talk? Okay, I think we're going to wrap up with one last model here. Let me check my time and see where we are. I think we're good. So this is something called the hope model. It's pretty critical. Why do we want hope? Because not having hope really is not great. Despair, futility, hopelessness, those are not helpful, especially when someone's feeling suicidality. They need to feel some reason to move forward. Hope is awesome. It rocks. Like, hey, we can do this. It'll help us move forward. It's motivating. We're willing to take on challenges if we have hope. If you feel like it's hopeless, sometimes we just lay down and quit, and that's not what we want from our patients. We want them to fight for life. Okay, so where does hope come from? So we believe it comes from confidence. So confidence rocks. It's awesome because it lifts that hope, right? So in this model, more confidence is going to drive hope. And the opposites of confidence are not great, right? Just anxiety, doubt, fear, worry. We tend to retreat or back into ourselves, as opposed to when we do have confidence, we've got that strength to move forward. So let's kind of look at the entire model here. Where does confidence come from? From this model, it comes from developing credible plans. that adjective or modifier of credible is really important. That it's not just a plan. Like if the plan is like, hey, I'm feeling suicidal, it's like, well, hey, go drink a beer and you'll be fine. Like, no, actually, that's not a good plan at all. It'll probably dull down your senses and increase the likelihood of suicide. So it's got to be a clear plan, a credible plan, not any plan. Now, notice if you work a credible plan, you tend to get success, and success lifts confidence. So 2 ways to lift confidence: developing a plan and then enjoying success. Now, if people aren't working it on that kind of far left bottom side, then you don't have a credible plan. If they're not following through, the plan by definition is not credible. So you have to kind of re-engineer that. How do we develop credible plans? It's really through understanding the fit between your patient and their world. What are their strengths? What are their struggles? What does their environment say? Who's around them? What is their emotional fortitude? What are their liabilities? So it's really that kind of broad-based assessment. Okay, so that's the HOPE model. Let me just say that I hope some of these ideas are helpful as you work with patients. It's critical work that you do, and if someone bumps into feeling suicidal, the hope is that they can lift their confidence for life and their motivation towards getting back on track. Brian?
Yeah, so we thought that pretty much concludes our presentation. So we thought it'd be helpful, even though you probably have these ready, if someone is having thoughts of suicide or anything like that in the military or within the VA or even outside the VA. Those are just important numbers to have if you're in healthcare and you have to deal, you come across these situations. So it's just some good info for you here. And then that's our presentation. By no means is that all encompassing of everything that motivational interviewing is. That would take weeks or months to do that. It's just some skills to maybe get you interested. If you hadn't heard of MI, a refresher if you have, or maybe get you engaged if you have some extensive training and get you back into using the skills within motivational interviewing. Brad and I provide online motivational interviewing training. It's in different modules of all different links to work on these skills. So you can just practice them. You just hit repeat, rewind, and you can learn those skills in that manner. Because we found that really when you go into the in-person sessions, it tends to be get as much as you can right there. It's not recorded, and it's tough to learn that way sometimes. So I find it more effective to just watch the modules over and over again and learn the skills. So that's all we have for our presentation. Again, this is almost a replay of what we did this morning via telecom. Now we're doing this on a video conference. So anybody that hasn't seen it, thank you for watching, and we hope to be invited back soon. It's been an honor to present to you. Thank you.
Thanks.